what we're going to do now is we're going to go through some scenarios. And each of these scenarios are specifically designed to illustrate the key points that Dan went over. And so these are scenarios that we want you to use in your training. We are going to create other scenarios also. We just have some basic ones now, but we're going to need to create, and you're going to see those. Those are things that will pop up on the Master Trainer portal on the website about other scenarios and other topics that we want you to cover. So we're going to go through these three scenarios, and then really kind of today the fourth scenario, if you want to call it a scenario, we're going to do is we're actually going to take out some of the widgets and some of the gadgets, and we're going to talk about them and demonstrate them, and we're going to do a little bit of hands-on playing, and we can talk about different ways to actually use those. Again, we're not in any way, shape, or form, working with or for any of these device manufacturers. There is a menu. We even have a slide that will demonstrate this. There's a menu of widgets or gadgets, whatever you want to call it, and you can sort of select from that menu. But as Dan said, unless we have some backups to prevent us from falling back into these age-old habits of hyperventilating, we're almost for sure going to do it. So we have to have some backups, and that's really the take-home message. We got to have some ways to do this. So we're going to talk about some different options, and that'll be our fourth scenario. So let's get to the scenario. So epic scenario number one: 20-year-old basketball player attempting a slam dunk and fell, landing on his head. 3-minute LOC, no seizure, GCS of 15. So this is the guy that, and you see these, patients that are playing sports and they got their bell rung, they had some LOC, and now you get there and they actually look good and they're awake. Normal vital signs, SpO2 of 98%. So you transport 2 liters of oxygen, a nasal cannula, TKO, 15 liters of high-flow oxygen, TKO, blood sugar transport. So these are your different treatment options. Obviously, this is to illustrate that point. This is kind of classic for what scenario? The person that is high risk for TBI. This is even really classic for what we call an epidural hematoma. He showed a picture of one of those. The person that has that lucid interval, and they look great. Kids will do this frequently, and then rapidly deteriorate. So in this treatment scenario, the patient's LOC deteriorates rapidly. No surprise there. Becomes deeply comatose. Pupils remain equal and reactive to light. Respiratory rate decreases. So now they're only breathing 5 times a minute. If you don't supply high flow oxygen, if you do supply high flow oxygen, it's 100% sat. If it's on nasal cannula, it's 95%. So 3 is the paradigm shift. 3 is what we want to shift into. But obviously that's not where we are right now. I mean, I'm just curious. Show of hands. How many patients that run on this guy that's awake and talking to you after he fell down, young guy? How many get any oxygen?
You have to force them into answer number 2.
Yeah.
If you can get them to number 1, you're doing good. But number 2 is
so high flow oxygen would really be a shift in practice, right?
But on a test, they're going to answer 15 liters. Oh, yeah. Wasn't it 15 liters?
And so what we don't just want is we don't want someone to answer the question properly. We actually want to translate into practice.
We're going to have to reach out and dispel rumors at the same time, because I just heard this morning in class that there's a study somewhere that suggests that O2 sats greater than 95% or 90%, you don't put oxygen because it'll lead to early cell death.
Yeah. We just talked about this.
Well, you know what? We'll come back to that. In fact, that's one of the caution. And what you'll really like, there's about 15 slides for each of these scenarios that we don't have to go through with all of you, but actually go through some of the nuances and the points and exactly the kind of things, so you won't be thinking, never heard that.
In essence, that's why we're here to discuss those things, because otherwise we could just give you the slide set. We could give you the provider slide set, and you could just go through, okay, hypoxia, hypertension, we could do all that stuff, but this is really what we want to talk about. We're
going to come back to the downside and the upside of why would we hyperoxygenate a bunch of people. What we're going to come back to what's the risk of downside versus the risk of upside of doing it, which is overwhelming in the literature, actually.
Yeah, Dr. G.
Most people are confusing the studies that show post-cardiac arrest patients that have return to spontaneous circulation should be kept 95 to 99% and not in
Yeah. There is some data to suggest that people have had cardiac arrest, that providing excessive oxygen actually is not good for the brain. But
Since you brought it up, most of those studies are studies that come out of ICUs where patients have been kept at too high of an FiO2 for too long, and often it's over days, in some cases over weeks. Here we're talking somewhere between 5 minutes and 2 hours at the outside, 3 hours at the outside, something like that. So that's part of the answer back, which is those studies are not about pre-hospital care.
and they're about a different disease, and
Yeah.
so it's a good point. So there was another question in the back.
I'm just curious how many would transport?
Great question. So
Transport them now, they're gonna transport them.
okay, another. So basically, the question was even your treatment number one. How many of these patients actually would get transported? The reality is, lots of them don't. This is actually a very, very high medical malpractice liability issue when patients, have a head injury but refuse transport.
Loss of consciousness. The key.
It's got to be a reliable.
Yeah, 20-year-old.
Yeah, the key is the loss of consciousness. This is not every run that you take that a person says, I fell down and go boom. If there is a convincing sense of loss of consciousness, and you know what, we might as well say this now. Most of us think of the really dramatic brain injured patient that we're going to save is the person in a high, goes off a motorcycle at 85, and you show up and they're comatose, and we can get them intubated and do impressive stuff in them and get them to the trauma center so they can take the clot out and all that. And the reality is that person probably has either diffuse axonal injury or a bad acute subdural, and the bottom line is that person's probably going to have a horrible neurological outcome almost no matter what anybody does. The reality is now you see the difference between primary brain injury and secondary brain injury. You'll see what happens to this guy if we did it right versus if we did it wrong. He has a trivial primary brain injury, right? He's talking to us, everything's fine, the axons, the neurons are working. But this is a person who can end up vegetative if he's not properly cared for and if we don't pay attention to him.
The really important thing about this one is, remember that one slide, the prevent defense. It's all about prevention. So that's kind of the take-home message. So let's kind of cut through this one. We went through this. Okay, so what do you do now? Here are your treatment options. An OPA and BVM at 20 respirations per minute. OPA, BVM at 10 breaths per minute. And it's tolerated. The oral airway is tolerated. BVM in preparation for intubation, then intubate and bag at 20, or BVM preparation for intubation, then intubate, bag at 10.
Or 4. And this is one of the points that we're trying to make, is we're not trying to be everybody's medical director. That's not the purpose of EPIC. In different settings, or if you're 3 minutes from the trauma center versus 27 minutes from the trauma center, all across the state, in every system, you may do something different. But 2 and 4 are
So 2 and 4. Although with 2, if they're tolerating an oral airway well, that's somewhat suggested that they likely need their airway protected. Right?
Is it fair to say that each one of these leads to it's a decision tree? If you make decision 1, you're going to leave here. Is it? And most of you that know me, I usually write at the top of my folder, "Shut up, Paul," so I don't stretch out a meeting. But I'm curious, could we not link these? In other words, if you choose option 1, it links you to slide 6, which is the option.
Yeah, we're going to give different outcomes.
Yes.
That's exactly where we're headed.
When you talk intubation, are you talking supraglottic airways as well?
We're not differentiating. We're just an advanced airway.
It is important for you all to know, one of the potential pushbacks is EPIC is telling Arizona how to manage airways, and it's really important that you know, no, the answer is, if the answer is, okay, what should we do, or which airway, or whatever, the answer is what we've decided with our medical director. But as you see, there are things that you can nuance within that freedom that can really help.
But if you're, he even talked about the drugs, the risk of those drugs that are powerful venodilators. If those are drugs that are going to go into your decision making to put in place an advanced airway, you have to be aware that those drugs, really high caution, those actually could take you down the path where you don't want to go, to hypotension. Okay.
On Paul's, is anybody else using like turning technologies or audience feedback technology in their presentations yet?
Bruce and JT and Amy are working out the details, but we're hoping to be able to make available to you the version of this where you use the audience response system. You know, so you've probably seen it in multiple, you know, they ask a political question and it's A, B, C, D, and you instantaneously get to see the graphics and so forth. We're hoping to put that into your hands. We'll have to figure out how to get it back and forth and so forth, but we're hoping to give that to you as another way to keep people attentive in the presentation.
Anywhere you see that little icon with the clicker, that's where there'll be a clicker scenario. We haven't got them in hand yet. They're supposed to be in the next day or two.
So high flow non-rebreather given immediately upon arrival. This is your outcome. Patient has an epidural evacuated, discharged several days later, neurologically intact, goes on to Harvard. Okay. And this was either 2 or 4, whether you chose BLS or ALS airway. Next outcome, high flow non-rebreather is delayed. Patient desaturates, becomes hypoxic. Neurons are affected and is difficult to correct with oxygen. Complicated hospital course with high intracranial pressures, ends up with low IQ, doesn't go to Harvard. Requires lifetime care by parents. All right, it's that black and white. It's that much at stake with whether we do this properly or not.
By the way, this is where to put in, if you anesthetize pigs with vecuronium, so you put them completely out, right? The typical pig, if you give them IV vecuronium at a large dose, within about 90 to 120 seconds, their saturation drops below 90. So they have about 90 to 120 seconds of apnea that then creates hypoxemia. If you preoxygenate them, and remember what that does is taking the lungs that are only 1/5 oxygen, right? Room air about 20%, and it gets them nearly to 100%, so you put 5 times as much oxygen in their lungs. When you make a pig apneic, they will take 8 minutes. Think about it. 8 minutes to become hypoxemic, because they're not in cardiac arrest. There's still blood going through the lungs, and now you've made the lungs a good reservoir for oxygen. So that's why, if in this guy, this is not made up. This is somebody who he got his non-rebreather at high flow after he stopped breathing, right, and started to go in the tank. He gets hypoxemic during the intubation, whereas if he was given the pre-oxygenation before, he doesn't get hypoxemic, and it makes all the difference.
Dr. Spade, are you talking about just a passive oxygen or?
That's right.
Because the classic old school concept of pre-oxygenation is actually hyperventilation with oxygen. And so you got to be clear about.
No, this is generic
oxygen.
Right, this is generic pre-oxygenation, meaning everybody who lost consciousness ought to get this, because if they're the person who ends up with a bad epidural, that person this may be all the difference in the world. By the way, I don't know about you, but the worst intubations in my career were intubations where people were saying, okay, it's 80% now, it's 78% now. I mean, it really helps you on your intubation, doesn't it? And so what the big studies show us is most of the time you'll never hear the alarms and the hollering people if you did a good job of pre-oxygenating, because we can keep the person non-hypoxemic for a long time if they're pre-oxygenated.
What we're really talking about is prophylaxing.
Yes.
Prophylaxing
I'm just
against
pointing out that
hypoxia.
I think the term pre-oxygenation is confusing a lot of people's minds with that old bagging them up thing. which
Yes,
is hyperventilation.
especially in the hospital. In the hospital, I suspect that there's not so much of that in the pre-hospital concept. That's a very good point, Dan.
And if you think back to your medic training, when you're in an anesthesia with an anesthesiologist, and what does he do? He puts them on oxygen immediately, and then he gets all the stuff ready, or he talks to you, which is what happened in mine, and then he finally paralyzes the patient, so the patient's fully apneic. And it's amazing how long. He just screws around, gets the equipment, he goes, see, look at this, here, hold this. And the patient's saturation bumps along at 100% for a long, long time. So it's real world, this works.
So, but of course, that's a very, very different controlled scenario. You're probably not going to have time to specifically preoxygenate. That's why you just put it on at the beginning. So in anticipation that things might go south, you've already done it. So I think that's really the point. This next one's really important. So the first two were BLS, were non-rebreathers. The second one, intubation attempted, very difficult, unable to see cords or pass the tubes. You know, a majority of these episodes, pre-hospital intubation, whether you document it or not, or whether you realize it or not, patients on a large proportion of these desaturate. They desaturate, you know, during the event. So it's very, very, very common. During intubation, patient becomes hypoxic if not preoxygenated with early high-flow non-rebreather from the beginning. So really what we're talking about is prophylaxing people at the very beginning in anticipation that you might need to place an advanced airway. All right. So these are some extra notes. Main points that any TBI patient can quickly deteriorate. We've hammered that home. And that high-flow non-rebreather oxygen for all potential TBI patients.
The next one.
Yes. And you talked about the pigs. Good. So any questions about that? Yeah.
Other thoughts?
Well, but this exact patient where I'll say I'm working in Florence and I have a patient who presents this way, who's alert and ready to type score, does everything, we put him on high flow too. Do we take him to the local community hospital?
Yes.
And then he crashes there?
Well, it's a great question. But again, like the RSI topic, we're not at all suggesting changing any patterns of referral or anything. That's a whole nother question. It's an important question, but that really will be up to your medical director, your offline protocols or online protocols.
In Mesa, we would have to take him to Scottsdale and
That's
this
simply
patient,
because of the
loss of
consciousness?
consciousness.
But we're
Not a hospital in the East Valley will take this guy.
So it's important, and that changes from region to region, but EPIC has nothing to do with changing referral patterns. It's a great question, though. Yeah. Another thing for scenario number one, if you have to go on to Crike because of this difficult airway, it turns into a bloody mess, and then they end up bagging the patient anyway. This is because the patient never has a reason to force an ALS airway. Do you want to talk about this at all? Or?
Yeah, remember, by the way, if they decide to intubate, what you do is you make it a hard intubation, but if they pre-oxygenated, they never see the cords, they go back to their BLS airway, and the patient does fine in transport. Which all of us who are really experienced intubators should have had cases like that in our career, where you get in there really fast and you say, this ain't gonna happen, I don't care who's in the room, and so you go back to mama, and you quickly get them to wherever you're going to, and things turn out well. That's how this one is built. It's built for, if they go to an ALS airway, that's fine to intubate, but the point is the next thing isn't, oh, I tried and I couldn't see anything, so the next thing to do is to cut the neck. That obviously is not where you're going. The point is, keep going back to a basic airway, and they can do well as long as the patient is pre-oxygenated.
Okay.
Yeah. Are you still advocating, I know lidocaine takes good 3 minutes to work, but pre-medicating with lidocaine on these patients with medicaine?
So another.
I told you they were going to ask me.
So this is a key question. So
They were saying,
okay.
we're not going to think about that.
All right. So lidocaine.
Yes, they are.
Lidocaine's really, really
Put-
interesting.
yeah, put the question, this
Okay.
is one for-
So we actually we didn't know how much depth we'd be getting into. So the question about pre-medication with IV lidocaine. There's kind of a school of thought in the past that giving IV lidocaine blunts the increased intracranial pressure. Who's heard of that? Who does that? Who administers lidocaine? Some people do. When I asked that question to our emergency department group, about 3/4 of the people actually do it routinely. When you go down and look at the actual evidence behind IV lidocaine, it's incredibly, incredibly thin. It's incredibly thin, the evidence that it actually decreases intracranial pressure. There actually is known evidence that lidocaine actually can induce hypotension. So you're actually trading
And seizures. It lowers seizure threshold.
yeah, but but what you're essentially doing by giving lidocaine is you're trading a theoretical benefit for a definite potential downside of causing hypotension. What was the number one thing that Dan put up? What is gold? What's money in this thing? Is perfusion, right? Cerebral perfusion. That's what you always have to fall back on. So again, EPIC is not going to profess to change any of your patterns if you're doing lidocaine, but any drug you give, you have to be really, really careful if it lowers blood pressure and lowers perfusion to the brain. It's a great question. I'm glad you asked it. Dr. G.
Henry Wang published some studies that showed that there was no benefit from lidocaine prior to that.
Yeah, looking at outcomes.
Yeah.
That's right. And by the way, John, thanks for pointing that out. The reality is the outcomes haven't been shown by anybody to be impacted. This is it's a theoretical potential.
So if you really want to look at it, I actually looked at this not that long ago. It was all data from ICU patients who, what they did is they measured their intracranial pressure as they were putting a suction catheter down their endotracheal tube. So they're already tubed, they're in the ICU, they're suctioning them, so of course they gag when they put that in, and now they randomize them to getting either lidocaine or no lidocaine, and they measured their ICP. So it's a totally different scenario, and they did it in about 20 patients. And that's where all the data from lidocaine came. And it's one of those great examples of something gets into folklore and it becomes, it becomes stone. And so, I really admonish you to look at any drug you're giving for a TBI patient and to be really careful whether it lowers blood pressure. Okay.
Great question, though.
Okay, I'm glad we got through that. Okay, so these are other notes for you for scenario 1. If your provider chooses to ventilate at 20 breaths per minute, which hopefully they don't choose that, the patient ends up with a serious neurologic disability and they don't get their EPIC provider card. Okay, the patient does not. This patient does not have impending herniation. His pupils remain equal and reactive. He has no lateralizing neural findings. So again, Dan put up the very, very uncommon scenario of impending cerebral herniation. It's not a common thing. We don't want to have the message be that someone has a bad GCS, well, they must be herniating. That's still just not true. Again, it has to be those findings of rapidly decreasing GCS, in the face of TBI. All right. So we described this as the classic epidural. We talked about that. Relatively minor primary brain injury, lucid interval, and then the secondary brain injury is really what we're trying to prevent.
Yeah, so this is the classic. You can convert this person. If you mismanage this person, we can convert what otherwise would be a trivial primary brain injury into potentially the rest of their lifetime. When this guy's 60, his 80-year-old parents are still taking care of him. And that's the way to think
So this is
about
kind of really epic group number 1 that we think we can really help. And so that's kind of why that scenario looks like that. And by the way, we would love to have you help develop other scenarios. We're going to have other scenarios, or even after you do some training sessions, refine these scenarios. Wow, these people, the providers ask this question all the time. So we need to actually refine it.